Assalamualaikum. So back कर लीजिएगा please. Back. हाँ. So this is a randomized control trial. अभी मेरे पास आए थे, उन्होंने बहुत सारी स्टडीज मुझे दिखाई कि ये स्टडीज हैं. मैंने कहा यार इतनी महंगी दवा है. Starting with the same point कि it has to be judiciously used. ठीक है, गवर्नमेंट ने इसको परचेज की हुई है, पेशेंट को पब्लिक सेक्टर में फ्री ऑफ कॉस्ट मिलेगी, बट its rule has to be defined where it has to be given. With that concept, we started this study, and this was the role of Ulinastatin in preventing severe sepsis and consequent morbidities and mortality in patients. So this is the trial which is registered with clinicaltrials.gov, and I'm presenting interim data. It is not yet published data, and study is ongoing. We are targeting somewhere around 200 patients. When we talk about multi-center, this is one of the hope. We can expand it to multi-center to increase the sample size of the same study and get meaningful results, because the data I'm going to show is promising. It might be very effective drug, but needs definitely a larger trial, what I have done. So disclosures, this study is partially funded by AllMed, and today my travel expenses have been paid by the AllMed. So that's what my disclosure is. But the data I'm going to present is completely scientific, which we have because the company or the pharmaceutical did not have any control over the patient selection and the management, and this is what all we did at ourselves. So the overview, we are going to talk about the study design and the sepsis and septic shock. I tell the slide is coming, so be patient, and we'll be discussing the main outcome data today. Next, please. So the stats, just skim through. This is the US stats. So last night I was making the slides, and just 1.7 million sepsis with 270,000 deaths in US, and 1 in 3 patients in hospital actually die of sepsis. And when we talk about the cost, look into the cost of antibiotics. On an average, in a public sector hospital, I am running ICU at JPMC, which is one of the largest tertiary care hospitals in public sector. 20,000 per day at least is the cost of the medications of 1 day of ICU stay in public sector. What to talk about in private sector? So, and when we are seeing 1 in 3 patients in hospital dying of the sepsis, this is an important element to us. And 87% of the cases actually get out of hospital sepsis. So identifying this is important. Next, please. And who are at risk? We can talk about patients who are elderly, patients who are who have got immune dysregulation, patients who have chronic conditions, diabetes, chronic kidney disease, and then they are those who had been hospitalized recently, surviving sepsis, which are recovering, for the children. Next, please. So the sepsis, when we talk about, is the combined, confirmed or a suspected infection with inflammatory response syndrome. This inflammatory response syndrome, when is suspected or confirmed with the infection, then it is called sepsis. But when the patient is having inflammatory response syndrome without any evidence or suspicion of infection, this is called SIRS, systemic. So there are infective conditions in which the inflammatory response may take place, then there are non-infective conditions as well. जब हम autoimmune diseases वगैरह की बात करते हैं, उसमें भी SIRS होता है. So it may have got some role there as well to looking into the. ये basically SIRS के ऊपर काम करता है ना, जो वाहन है या Ulinastatin is working on the pathophysiology of the SIRS, and that's where जो डॉक्टर साहब ने बात की अल्ताफ साहब ने कि शायद जो विंडो है इसकी गोल्डन विंडो है जिसमें आप ट्रीट करते हैं, दिस इज द टाइम व्हेन द पेशेंट इज हैविंग एक्चुअली SIRS and it has not ended up in a severe sepsis or septic shock. Next, please. So when we talk about severe sepsis, तो sepsis के लिए यानी कि इन्फेक्शन है और inflammatory response है, हार्ट रेट बढ़ा हुआ है, पेशेंट का जो है बीपी ड्रॉप कर रहा है या टेम्परेचर हुआ है. तो जो inflammatory response के साथ अगर organ dysfunction की evidence मौजूद है, तो that makes the case of a severe sepsis. तो जो SIRS वाली स्टेज है, अगर हम उस पर ट्रीट कर रहे हैं इस पेशेंट को, सिवियर सेप्सिस में या सेप्टिक शॉक में पेशेंट नहीं एंड हुआ है, तो दैट इज द टाइम, बेस्ट टाइम और गोल्डन विंडो प्रोबब्ली विद दिस ड्रग which will be get the best results, and this is what not supported by the data. हमने अभी इसकी सबग्रुप एनालिसिस नहीं की, स्टडी ऑनगोइंग है, तो we will come up with the end of the study जब हम पब्लिश करेंगे इस स्टडी को. नेक्स्ट प्लीज. तो सोफा स्कोर को हम यूज करते हैं। सोफा स्कोर ऑर्गन डिस्फंक्शन स्कोर है, आईसीयू के अंदर बहुत कॉमनली यूज होता है। इसके अंदर जो है 1 to 4 इंडिविजुअल ऑर्गन को देते हैं, लंग्स को, मेटोलॉजिकल पैरामीटर्स, लिवर के, हार्ट के, किडनीज के और ब्रेन के। So I just go into details of SOFA scoring, लेकिन SOFA score अगर 6 से above होता है, less than 6 है तो 33% mortality risk है, and if it is more than 12 it is जो है 95% mortality risk होता है पेशेंट का आईसीयू के अंदर एट द टाइम ऑफ एडमिशन, एंड देन रीअसेस किया जाता है। नेक्स्ट प्लीज। और सेप्टिक शॉक जब हम कहते हैं, जब पेशेंट का मीन आर्टिरियल प्रेशर आफ्टर द आइनोट्रोप एंड क्रिस्टलाइट्स नहीं राइज कर रहा और लैक्टेट उसका बढ़ना शुरू हो जाता है पेशेंट का, और वो कम नहीं हो रहा विद ऑल योर एफर्ट्स ऑफ हाइड्रेशन एंड गिविंग द आइनोट्रोप्स नॉट रिस्पॉन्डिंग, दैट सेप्टिक शॉक। मल्टी ऑर्गन डिसफंक्शन जब सोफा स्कोर्स मोर देन 2, मोर देन 1 ऑर्गन के अंदर अगर आपको मिलते हैं तो वो मल्टी ऑर्गन फेलियर डिफाइन होता है। नेक्स्ट प्लीज। नेक्स्ट, जो आउटकम हमने डिफाइन किए थे अपनी स्टडी के, कि वो वर्जनिंग अगर हम डिफाइन करते हैं, अगर तो पेशेंट का सोफा स्कोर 2 या अबव हो जाए बेस लाइन से एट द टाइम ऑफ एडमिशन डे 5 के ऊपर, नो चेंज अगर पेशेंट का सोफा स्कोर डे 5 के ऊपर और डे 1 के ऊपर सेम रहता है, इंप्रूवमेंट अगर एनी इंप्रूवमेंट इन द सोफा स्कोर फ्रॉम डे 1 टू डे 5 इंप्रूवमेंट। So these are the primary outcome data which you are looking for. Next please. सेकेंडरी आउटकम्स के अंदर पेशेंट के अंदर प्रिवेंशन ऑफ द सेप्टिक टू सेप्टिक शॉक प्रोग्रेशन फ्रॉम द सेप्सिस पेशेंट जो है सेप्टिक शॉक में या मल्टी ऑर्गन फेलियर में जा रहा है पेशेंट, या मोर्टेलिटी डे 7, डे 14, डे 28 के ऊपर, नंबर ऑफ डेज ऑन मैकेनिकल वेंटिलेशन टोटल जो पेशेंट वेंट के ऊपर थे हमारे, और पेशेंट नंबर ऑफ टोटल डेज इन आईसीयू। ऑन हॉस्पिटलाइजेशन कॉस्ट वुड बी मॉडल्ड, क्योंकि बहरहाल हमारा पब्लिक सेक्टर हॉस्पिटल है, इसमें कॉस्ट इन्वॉल्व नहीं होती है, पेशेंट्स चार्ज नहीं किए जाते हैं, बट वी वुड मॉडल दिस ऑन द बेसिस ऑफ द मीडियम कैटेगरी एंड हाई एंड प्राइवेट सेटअप की अगर ये केयर वहां दी जा रही हो तो पर डे कॉस्ट कितनी है, वहां की कॉस्ट ऐड करने से पेशेंट को ये still with this price is it cost effective to add on these sick patients or not. So that is again a secondary जिसे कहते हैं एनालिसिस, इसकी हम कॉस्ट एनालिसिस एग्जामिन करेंगे। नेक्स्ट प्लीज। So this is the medical ICU building of KPMC. It's 4-story building you can see here, and that's where the study has conducted. 121 patients have been enrolled in this patient. We have targeted around 200 patients in this study. It was IRB approval was taken from KPMC, and it has been approved for clinical trials.gov as well and registered there. Next week. Randomization was based on the draw method कि हमने एक जो है पर्चियां बना के रखी हुई थी, और पेशेंट्स जब आते थे तो नंबर्स के हिसाब से उसको जो है ड्रॉ करके और उसको रैंडम नंबर के जरिए जो है उसको पेशेंट को या तो कंट्रोल ग्रुप में होता था जो स्टैंडर्ड ऑफ केयर पेशेंट को मिलती थी, या रॉन ग्रुप या यूनिवर्सिटी ग्रुप में होता था। इसमें डोज हमने जो है 3 MIU TID का डोज यूज किया था, दैट वाज फॉर सीवियर सेप्सिस, क्योंकि हम आईसीयू में स्टडी कर रहे थे। हमारा जो एक्सपेक्टेड हम लेवल 3 केयर देते हैं आईसीयू के अंदर, तो ज्यादातर पेशेंट ऑलरेडी वेंट के ऊपर हमारे पास रिसीव होते हैं, तो ये पेशेंट जो हैं वो बहुत सिक होते हैं, तो वी यूज्ड कि हम अंडर डोज करके और फिर नॉन कंक्लूसिव ट्रायल पे जाएं, तो बेटर है कि हम एक प्रॉपर डोज जो रिकमेंडेड डोज है उसके ऊपर उसको ट्रायल करें। तो 3 MIU TDS डोज वाज used for 5 days in these all patients. Next please. Next. Inclusion criteria: any patient admitted with in ICU with 18 above with sepsis or severe sepsis diagnosis with systemic inflammatory response with suspicion of infection, and they are consenting or the family is consenting to be included. Pulmonary hepatic failure, acute poisoning, chronic kidney disease, immune thrombocytopenia, cardiac failure with EF less than 20, and those of COPD. तो ऑर्गन फेलियर एक्चुअली हमने एक्सक्लूड किए थे। उसके पीछे रीजन ये था कि ऑर्गन फेलियर के जो पेशेंट आते हैं, जो क्रॉनिक ऑर्गन फेलियर के साथ आते हैं, वो सोफा स्कोर बहुत हाई होते हैं, तो दैट वुड एक्चुअली बायस होल स्टडी टुवर्ड्स द पुअर आउटकम। तो दोस पेशेंट हु आर नोन फॉर ऑर्गन फेलियर वर एक्सक्लूडेड। नेक्स्ट प्लीज। तो दीज आर द पेशेंट डेमोग्राफिक्स जो अभी तक हमारे पास पेशेंट्स हैं। Just gender distribution, the mean age in the patients with the control group was again 45 and 46. You can see any difference there. Male, female का भी again there wasn't any difference. Female patients were more in placebo group or less in overall female patients के admissions भी relatively हमारे पास कम है ICU के अंदर जो है। Diabetic patient you can see is the same, and hypertensive chronic kidney disease with stable chronic kidney disease. There were few patients again. Patients with the sepsis, respiratory, and you can see organ failure patients, underlying infection, site of infection, you can see it was comparable. Next, please. Diagnosis based on it was mixed as it is a medical ICU. You can see the diabetic ketoacidosis, acute hepatitis, decompensated liver disease. 2 patients were added, and then dengue fever, and then enteric fever, tuberculosis meningitis, and thrombotic thrombocytopenic purpura. 2 patients were included. They were not ITP, as that was one of the exclusion criteria. Next, please. Again, pie chart. Next, please. Now, these are the basic results. You can see patients with the sepsis, 35% of the patients with sepsis, and 30% patients with the Ulinastatin group were having overt sepsis. Shock patient, 49% and 50% in the Ulinastatin group. Multi-organ dysfunction at the time of admission, 14%, and again 25%. So there was some difference because these were not controlled, and data is still, we are collecting the data, and the difference of the shock was significant in these patients. Next, please. Profile scores, back करें. And you can see the difference day 1 to day 5 के अंदर. Control group के अंदर जो patient sepsis में थे, it was we are around 6% reduction in the patients with sepsis. But what we see in the Ulinastatin group, there was a significant, somewhere around 25% reduction in the sepsis group. So the patients were improved, but the number was low. That's why the PAPLE did not come out to be significant. And then in the shock, again, 50% of 49% goes to 8% reduction. But similarly, 8% reduction was seen in the septic shock patient. I think there wasn't much of the difference there. Next, please. The difference came with again SOFA score. Similar change was seen Ulinastatin group and the placebo group. But what was different was the 14-day mortality. You can see there was 11% reduction in the mortality, the 7% reduction at day 14 mortality, and overall mortality of the both group was, next please. In control group, it was 19%, in the Ulinastatin group, which was 13% mortality. That makes the 32% reduction in overall mortality by using Ulinastatin in these severely ill patients in ICU. So, in summary, the sepsis patient 9% versus 17% reduction. That was quite significant. Multi-organ dysfunction was 6% worsening versus 5% improvement. That again was very important. And with a shock patient, the data was comparable in both groups. Both shows 8% reduction, and they not have been very much effective. But again, with multi-organ dysfunction, before ending up in a shock, or the patient with the sepsis showed significant improvement. Next. And SOFA scores, again, the SOFA score did not vary too much. That makes the case again that it is anti-inflammatory effect. And overall mortality, 32% reduction from the control arm was again one of the promising that we might continue this study for a larger sample size to get clear outcomes in these patients. Thank you. Any question on this study? Most of the patients were actually breakup हमने अभी कैलकुलेट नहीं किया क्योंकि जो ongoing study थी इसकी analysis जो patients हमारे तकरीबन 70% patients जो हैं वो actually ICU में ventilators जो patients हैं तो overall जो आपको picture नजर आ रही है mix and match है जो हमारे पास HD patients हैं वो कम enroll हुए थे जो severe sepsis और उसमें qualify नहीं करते थे हमारे लेकिन ये कि 70% patients are actually on ventilator. Yes, sepsis का criteria है जो SOFA scores है ज़्यादा जो mean SOFA score was somewhere around 6. That means that at least 2 or 3 organs are already damaged by the time patient is taken up. The interim result shows 30% reduction with but the group which was identified by Sarah as well and commented his sepsis, septic shock did not show that improvement, but sepsis did show. Multi-organ dysfunction before going into the septic shock did show. This may it was preventive once the when the patients are already on the shock with multiple inotrops and ventilator, probably that is too late to start with. And patients before that, the patients an HDU at the time of admission before on multiple inotrops should be the ideally targets for the drug. That would be the target, and this again I must use that the golden window is intercepting the process of inflammation before it goes into the vicious cycle, and which is not being reversed. Uh, we will come up with subgroup analysis because we did check for IL-6 and PCT baseline, and we'll look the mortality analysis, and by the time we publish it, definitely we will have the answer that was it effective in those who were having high inflammatory markers, or those who had, because we did not have low inflammatory marker, we had the patients with full-blown sepsis, most of them. So none of actually had very normalish looking inflammatory marker, but we would like to look into the ROC curves and with the analysis that was it effective. The inflammatory markers were dictating which patient is going to respond or not. We did not had that as well. We are thankful to the Allmed they sponsored. Allmed actually sponsored the kits to the hospital, and then we monitored those patients with that. सब स्टैंडर्ड ऑफ केयर तो हर मरीज को मिल रहा था ना. With JPMC is the largest hospital now officially declared of Pakistan, and ICU के अंदर हमारे पास most of the patients are high on antibiotics के ऊपर होते हैं, to be honest, नीरो और कोलेस्टेन और एंटीफंगल्स, ये सारी चीजें अक्सर पेशेंट्स को चल रही होती हैं. लेकिन ये कि कंपैरिजन में randomization है ना, वो तो दोनों ग्रुप में चल रही है ना. If one group is showing the difference which is different of that, may be likely जैसे कहते हैं ना cause of that, तो वो सिमिलर चलती हैं. जो प्रैक्टिस है वो तो अपनी जगह पे चलती है. पेशेंट की जो एंटीबायोटिक मैनेजमेंट है वो तो एज ए रूटीन चल रही थी, उसको हम डिक्टेट नहीं कर रहे थे. नहीं, we started with trial with only most of our patients were in the, आप देखेंगे तकरीबन 50% से ज्यादा जो है ना वो सिवियर सेप्सिस वाले पेशेंट हैं, मल्टी ऑर्गन डिसफंक्शन वाले पेशेंट्स हैं. तो वी हैड दिस डिस्कशन वेरी क्लोज कि हम लोअर डोज के ऊपर से स्टार्ट करें. इवन जो सेप्सिस के हमारे पेशेंट हैं वो भी जो रिकमेंडेड डोज है वो 3 MIU TDS वाली है, 2 to 3 MIU है. लेकिन जो सिवियर सेप्सिस सेप्टिक शॉक वाली है वो 9 to 12 MIU पर डे है. तो वी एंडेड अप विद दिस कि 9 MIU हम रखते हैं, क्योंकि कंफ्यूजन ना हो कि किस पेशेंट को क्या देना है, क्योंकि पेनीज होते हैं इवनिंग नाइट के अंदर हमारे पास. जी जी, तो हमने तो एक्चुअली हायर एंड से ही शुरू किया, बिल्कुल कंट्रास्टिंग टू द अल्ताफ साहब जिसे कहते हैं ना, he started with a lower dose and we started with a higher dose. तो सारे पेशेंट्स को हमने फिलहाल तो उसी डोज पे रखा था 9 MIU के ऊपर. वी कैन दिस कैन बी डिस्कस कि भाई जो पेशेंट्स हमारे जो लोअर सोफा स्कोर्स के ऊपर हैं या जो इन्फ्लेमेटरी मार्कर्स जिसके नहीं है उनको वी कैन 24 आवर्स के अंदर या आफ्टर 12 आवर्स वंस वी गेट द रिजल्ट्स कैन वी स्टेप डाउन. दिस इज वन ऑफ द स्ट्रेटेजी वी कैन ट्रायल डिजाइन मॉडिफाई करेंगे. लेकिन ओरिजिनल जो ट्रायल डिजाइन था उसमें ये कि